Good morning or good afternoon, everyone, depending on where you happen to be. My name is Tina Nelson, and we are going to get started in just a couple of minutes here. We're going to wait until 3 minutes after the hour just to give people time to come in from other meetings. So thank you for joining, and we'll get started shortly. Hello, everyone. We're going to get started at 3 minutes after the hour just to allow people time to transition from other meetings and fill up water bottles. We'll get started shortly, and thank you for your patience. All right, we have 3 minutes after the hour, so we'll go ahead and get started. Thank you, everyone, for joining us today. My name is Tina Nelson, and I welcome you to our webinar entitled Engaging Physicians in QIP's Work Through the ABMS Portfolio Program. And I point out that this is a one in a series of 3, which we'll talk about a little bit more later. Next slide, please. So this should be kind of status quo nowadays in 2024, but just to make sure, we know that doorbells ring, cell phones ring too, dogs bark, babies cry, kids knock on doors, and all of those things. We'll do our part by trying to keep everyone who isn't speaking on mute, and we ask you to do the same, but know that it's okay. Next slide, please. Right, so we have a few goals for our call today. First, we want to share some specific portfolio program details about structure and other parts of the programs. We want to provide you some examples of established programs that you'll hear from in just a few minutes. And then most importantly, provide you tangible takeaways so that you can implement this program in your organization if you determine that it's the right decision for you. Next slide, please. So these are our speakers for today. Ms. Liz Kaufman from the Children's Hospital of Philadelphia. Michael and Johnny are both from Lehigh Valley Health Network, and we'll hear from them in just a moment. Before that, I want to give you just a little bit of information about their organizations. Next slide, please, Spencer. So Children's Hospital of Philadelphia, as you can see, is a children's hospital. They have 2 inpatient hospitals with 50 care network sites across their region, physicians almost 2,100, and PAs that are served through the portfolio program are almost 200. And then patients, they say they have 29,000 annual admissions plus. Regarding their portfolio program specifically, it is located in the Center for Healthcare Quality and Analytics, or Quality and Safety, and is led by their Chief Safety and Quality Officer, and has approximately 0.2 FTE. Next slide, please. And for Lehigh Valley, similarly, this is in Pennsylvania. They have just over 1,700 physicians that they serve, with advanced practitioners being just over 1,100. Regarding specifically their portfolio program, it's located within the PPO, and the two gentlemen that you're going to hear from today, Michael and Johnny, run that program. They have about 4 FTE between all of the different staff that are participating. And with that, we'll go ahead and get started. So Liz, I'm going to start with you today. Could you please tell us a little bit about why you joined the portfolio program and why your organization has stayed in the portfolio program?
Absolutely. So we have been a portfolio program member in some way, shape, or form. We started with just the pediatrics board, but then in about 2017, we became ABMS, more broadly portfolio program sponsors. And since that happened such a long time ago, I can't speak directly to it, but I do know that when we joined this portfolio program, the original intent was twofold. It would allow us to set up a structure that would let us review and understand the quality improvement work that was already happening in our very large organization. And it provided us with a way to directly support our physicians in their professional requirements. And then that we believed would have some trickle down benefit to ensuring that our patients were receiving the best possible care. We've stayed because we found both of those things are true. And the added benefit that we've been able to see in the past couple of years is that having this sort of centralized location for this type of work where people are coming together allows us to make connections between areas that may be siloed and connect people to resources that they may not have known. And so that's been also very beneficial for our organization.
Wonderful. Thank you for that. Do you happen to have worked with any other specific sponsors while you were kind of making that decision to join the ABMS portfolio program?
Yes, I believe, I'm sure we consulted with many, but the ones that I know that we talked to a lot were Cincinnati Children's and Nationwide Children's, specifically because we knew that there were other children's hospitals, so they had more specific and unique perspectives.
That makes sense. That's perfect. Thank you. By the way, I failed to mention to everybody on the call, if you would like to raise your hand while we're speaking or throw comments or questions into the chat, not only do I suggest you do it, but I encourage and invite you to do so. We would love to have this be as interactive as possible. So thank you for that again, Liz. Michael and Johnny, how about you guys? Why did Lehigh Valley decide to join the portfolio program, and why have you guys decided to stay? This is the right place for you.
I can go first, Mike. So my name is Johnny Stokel, and like Tina said, we're in the Allentown area at Lehigh Valley Health Network. And back in 2019 or maybe late 2018, when we were looking at joining the program, the organization had started an application and really wanted to, I think for similar reasons, get invested in kind of rewarding our clinicians for the QI work that was already going on. And seeing that as a big plus to clinicians who are doing this work, finding more meaningful ways to get to earn CME for activities that are already happening. But also, I'd say two other components is that we were hoping was really to build upon our quality improvement and quality culture, and kind of be part of that glue that holds different parts of the organization together. And I'd say we found all that to be certainly true as we've kind of started early in 2019, our first couple projects, and have kind of gradually built the program from there. And it's definitely been personally one of the most meaningful professional experiences that I've had, to see the work that is going on across different silos, across different specialties, professions, and just to be a part of that and see how we can couple the CME benefits to those initiatives.
Absolutely.
Yeah, and I can add a couple things there too. I think, to Liz's point also, part of the effort is to centralize the quality improvement work. So we had a lot of siloed work, a lot of quality work going on across the organization, and it's a big one, but we didn't have that centralization. So I think this program has definitely helped us to get there, to not only centralize the work that we're doing internally, but to also offer that portfolio program out there. And there's also an aspect of physician well-being. So a lot of physicians, borderline burnout physicians that are doing a lot of work, not only to take care of the patients, but administratively to do QI work and other things. I think it gives them some purpose. We help them. Hopefully they're successful in their project and implementing it, and that gives them a little, sense of accomplishment.
Sure thing. Great. Thank you. Thank you both. Thank you all.
Well, we also worked, I'm sorry,
No,
when
go
it comes
ahead.
to who we worked with, the University of Michigan, Van Harrison was incremental in success, but also we've worked with so many different organizations. I think UCSF, the University of California, San Francisco did, helped us a lot. And then Cleveland Clinic. We've reached out to a lot of folks, a lot of times through the ABMS meetings and your annual conference. We've really run into a lot of people that have helped us a lot along the way.
That's great. So it sounds like everybody had help from other organizations while you were kind of navigating this path to becoming and even staying in the program, which is great because that's what we're trying to do, is cultivate that type of community. So thank you. Thank you, everyone. Johnny and Michael, I'm going to stick with you. Can you talk a little bit about the structure of your program and where it's located within the organization? I know you touched on it a little bit, but can you go into that in a little bit more detail?
Absolutely. So our program is set within our provider organization. So the umbrella a little different than others, where maybe traditionally we see it in a CME department or something like that. So we are in the part of the organization that isn't strictly operational, but is historically the physician group and now the clinician group. So including employed, independents together. So what that's given us is, in our particular organization, a stable platform it's been a stable funding platform for one. Oh, my auto light just went off. It's also been a place where we can reach independents as well as employed clinicians fairly easily. And that's been part of our mission. And we then collaborate with our Department of Education pretty actively, right, on maintaining our compliance with ongoing ACCME and ABMS guidelines. So we don't necessarily function from our Department of Education, but work closely with them, if that makes sense.
It does. Do you have that type of relationship with quality or any type of connection with them?
For sure. So what's kind of happened over the years, certainly as you engage project leads in different projects, you just begin to get to know who are the people that are doing quality work. So there's sort of this network, informal, of individuals who are just passionate and showing up every day and doing this work, and then new people that you didn't really know, maybe want to learn. And what that's sort of led to in our program is an additional training avenue that we also oversee, where we do quality improvement training and train clinicians in looking to up their skill level. So this is kind of separate from this program, but it really complements ours, and the ABMS program enabled us to do that. And that's created a more formal relationship with our quality quality department, I'd say, as they've kind of sponsored that work.
Sure. Great. Thank you. Liz, how about you? Can you talk a little bit about the structure and the location of the program within CHOP?
Yeah. So our structure has evolved over time. But where I sit, where sort of the more program administrative management sits, is within our quality department. Because we serve more than like our Department of Pediatrics, we wanted to make sure that happened. But we sit in quality, and then we have a multidisciplinary steering committee that meets and guides, that involves physicians and nurses and other quality improvement experts from all across the hospital that sort of end up meeting and guiding all of that work.
Incredible. Along those same lines, how do you feel like, and I know you mentioned earlier that you weren't there in the beginning of this, but maybe you can speak to it a little bit in any case, how leadership was brought into this. How do you guys get and maintain leadership support for such a program?
I can actually speak a little bit to this because we, the founders, I will call them, actually published a paper way back when about how they did this. And they spent a lot of time getting that buy-in. But ultimately, sort of what were the main selling points were that it would reduce that individual administrative work for our physicians, which was often framed as busy work, and that time burden, so that our providers were no longer relying on some standalone modules. And so getting that, pitching that was really the key, and then tying that in with our commitment to quality improvement and culture made that investment happen.
Sure. Thank you. Johnny and Michael, what do you guys think about Lehigh Valley and how you were able to get and maintain leadership support for the program?
Yeah, I think, part of the program, or the emphasis on starting it up, came from leadership. They recognized it, as Johnny had mentioned earlier. They had tried to start up a portfolio program previously, so they were already on it to begin with, and it didn't hurt actually that we had somebody, one of our leaders, Grant Greenberg, who actually worked at University of Michigan and worked with the portfolio program in University of Michigan. So some of our leadership was familiar with the benefits of the program.
Great. Thank you. Michael, how do you think, what has been the most effective way that you guys have spread the word within the organization about the program? And it's interesting to ask that question based on what you just said. Previous folks had tried to start it. A couple of hiccups later, you guys were able to start it. So how have you spread the word about the program?
I think we were successful in part because, we started at what we referred to as a roadshow. So we went to every executive quality meeting we could get into, board meetings we could get into, quality forums, whatever we could, show our face and talk about the program, let them know that it was coming, and continually let them know, how we're doing and how we're progressing. And I think that really helps to spread the word.
Mm-hmm. Do you have anything to add to that, Johnny? Looked like you were about to say something.
I just say it has evolved, and initially we were doing more recruitment, and now it's more of a how many projects can we handle, and honestly, the word, I think, once you have a program going for a few years, people know about it. So and word of mouth kind of can also take over. So for instance, once we had one rheumatology project, the next year we had another rheumatologist come, and now we've had 7 or 8 rheumatologists do projects. So there is sort of that word of mouth component, in addition to the kind of making sure we're sharing in strategic places. I think the ongoing reporting back of, if you're starting a program and interested in kind of maintaining it, reporting back on that ROI, whether it's the tracking the meaningful quality changes, the improvement changes, the qualitative comments that your leaders are giving about how it's changed their practice and maybe their outlook, collecting and really gathering and reporting on all those things. It's a pretty feel-good story. And so that's something that you want to communicate.
Thank you. Liz, how about you?
Yeah, so very similar. Way back when, there was an extensive advertising roadshow where they went to every department meeting, every division meeting, and sort of tracked down every physician who may need credit within the first year or two they got started to get everybody sort of set up. And after sort of several years of that, once this program became part of the culture, it's so well known that we don't really have to do anything projects come to us, or there's somebody in a meeting that will say, hey, this is probably MOC credit eligible. We do, include the general annual reminders through our physician affairs, and do a sort of any new faculty coming on get sort of in their orientation packet, do have the information. But it's very much more passive, which likely because of all of that initial investment in
Sure.
word of mouth.
Sure. And I think that's great. I can just picture, people sitting around a boardroom table and somebody going, wait, is this available for MOC? And like, that is the greatest thing since sliced bread, I think. I'm going to take a pause for a second because we have a question from Miriam Harden. She asks, what is the process for offering CME credits for the portfolio program in addition to allowing diplomates to earn MOC or continuing certification points?
I can speak how we handle that. It might be a little different at each organization, but for us, so CME is awarded through our Department of Education, and so we directly submit the MOC Part 4 credits to ABMS. But for CME, we kind of have a reporting structure that is now really automated with our Department of Education, where we have kind of the boxes that need to be checked, and they want to see the approved application, and we kind of have a shared file there, and then we notify our contact in our DOE department toward the end about what was done and who's testing after we've gone through that process, who participated in the project. So there's a little more details in it than that, but more or less we partner with our Department of Education, and they award the credits directly to the physicians for CME in addition to MOC.
Gotcha. Liz?
For us, we sit in a different area than our CME office, which we have our own standalone. So usually we kind of will work in tandem. If somebody is asking, if I get a question about it, I immediately know who to contact, and they also know who to contact for CME knows who to contact for MOC. So we just sort of figure out those contacts and work in tandem. But so I cannot speak to the details of getting the actual CME, but we do work sort of together on that in a partnership.
Okay, great. Along those same lines, Liz, what internal processes or procedures, like main processes or procedures, have you had to put in place in order to make this program work, in addition to what you're just talking about working in tandem with CME?
Yeah, we originally had we've done a lot of work in the past couple of years to completely revamp processes so that we can have fewer FTE because we have sort of foolproof processes. So the first thing we've done is we've made everything entirely online. Our attestation process for people who are doing it, our application process, and our notifications. We do a lot of auto routing, and so that is the biggest process that we think makes it simple, because it's sort of all included in a single system. The other, sort of procedure process thing that really works is having that single point person who is familiar with the QI and can triage and prepare information for people who may not be as familiar with, what the requirements are and what the needs are. And that's really that sort of point person who can do a lot of the pre-work with groups has been really helpful for when we do have our steering committee meetings, because there's more meaningful discussion. And that's been the biggest asset to our program.
Great, thank you. Johnny and Michael, how about you guys? Internal processes and procedures, like the main things that you've had to put in place for this program.
I think I would note that, we started off with a great mix of executive leadership and quality champions that support our program. So we have the funding and resources. That's so important to have their support.
Yeah.
So you have that funding and you have the resources that you need to pull it off. And we have great resources on our individual team. So we have, of course, Johnny, our clinical leader, and we also have some good program and project management and administrative folks on our team. So that helps to have a good mix of people. I don't know if everybody can have several people on that team, but I think I would recommend having a good mix of people there. And I think, Johnny mentioned our quality improvement training program earlier. It's not, it kind of runs alongside our portfolio program, but there's linkage in that people that come through our quality improvement training program are required to also run a QI project. So to enhance their training and to enhance their understanding about how to run a project. So I think that's worked for us, in tandem, and it's worked for us really well.
Mhm.
And
Great,
just to get
thank
into the weeds a little bit on what Liz was talking about, we similarly, have had to kind of evolve our program processes over the years. It's a continuous improvement thing, like anything else. So, we use REDCap for our enrollment disclosures and attestations. We, have kind of gone through a couple iterations of applications and in different formats to try to make that more automated and less work that's created. So it's definitely an ongoing process, and but kind of keep advancing that each year to try to make efficiencies.
Absolutely. We do the same at our level of the portfolio program. We're constantly doing the same thing. So we can very much appreciate that. Johnny, what would you say are the types of projects that you guys submit? Like clinical, non-clinical, everything in between, mixed? What would you say is the types of projects that people are working on that are being submitted at Lehigh Valley?
Right. So I think if you start a portfolio program, it can really take on kind of the flavor and context of your organization. Because I'm a primary care clinician, I'd say, and the big three are, IM, FM, and PEDS in terms of numbers. We started our focus there. What we've found is that as the program slowly spread over the last few years, we initially were more primary care ambulatory centric, so more clinical in that area. But we've really diversified more into inpatient, hospital, multi-specialty, and now we just kind of a mix of things from all over, mostly clinical, I would say,
Okay.
but kind of from all different departments.
Gotcha. Thank you for that. Liz, what about you guys at Children's Hospital of Philadelphia?
It could probably, as expected, we have a lot of pediatrics based projects, but we do sort of run the gamut here because the content of those varies fairly wildly. So we have a bunch of projects related to physician well-being, to central line infections, to patient flow in a specific waiting room at a specific location, to STI screening. So we try, and we've been working very hard to try and make it as broad as possible, as long as we can really tie that back into patient care and
Sure.
how these impact the patient. So we have approximately between 12 to 15 projects a year. But there are definitely projects we have that have sub-projects nestled within them,
Sure.
because we love a tangent here.
What kind of participation are you seeing in those different types of projects between physicians and PAs?
We have a very flexible policy. We used to have, when we were getting started and ramping up, we used to say we needed at least 5 to 7 people. But we've certainly decided that the content for us is more important now that we have the program structure in place. So we have projects where there's only 2 to 4 physicians working on a very small thing. But then we also have projects that have over 100 physicians working on similar work, including external physicians. So, just for context, last year we granted over 259 physicians credit and processed nearly 300 attestations across all of the boards that we have here.
Oh no. Oh, you're back. Okay, you froze for just a second there, Liz, but we got you back. And Johnny and Michael, what about you guys? What do you see in terms of participation?
Yeah, I think it truly varies. And we had a mega project during COVID where we had close to 400 participants in the one project, but that's really the exception. I mean, usually we have larger projects that can run from 40 participants all the way down to single practice, projects that's focused within a single practice with maybe just one physician or 4 or 5 physicians. So really, whatever anybody's willing to do when they come to us, whatever size it is, shape or form, we're willing to support them. I think we probably average about 20 to 25 projects per year currently.
Okay.
And then over the years, it looks, I did a quick number, and it looks like we average about 9+ participants per project over the years that we've been in the program. So decent average.
Right. And have you received any feedback, or do you receive any ongoing feedback from those participants with regard to participating in these types of activities?
We do. I don't, Johnny, feel free to jump in, but we have a project lead survey that we send out to all of our project leads once their project concludes. So we get that feedback within that survey. And it's been really, really positive. I mean, we have a scale up to 5, and usually we're in the 4.5 range when it comes to feedback on the questions that we have. So really, it's been a positive experience for them. And our executive leadership, again, has been very supportive. We get very good feedback from them too, because they see the results, and I think it enables them to really focus in on some of the improvement work that needs to be done around our goals and our priorities within our network and within Valley Preferred and LVHN. So we get some really positive feedback from them.
I'm making a note of that, to get good feedback from leadership. That's great.
The attestation, when people kind of say, hey, I finished this project, I participated meaningfully, they also have an opportunity to answer 4 questions that talk about their experience in the project. Those go directly to the project lead. So we don't do a ton of analysis on that in depth. We take a peek at it, but really that's for the project lead. And so that's kind of a way for them to get that closed loop of, hey, what did people think of their experience? And so, generally we don't hear too much directly from participants, except like they're happy for their credits. But it's what we try to do is talk to the leads who are really kind of the point people and see, how did that experience go? What were your learnings? What could have been better from a program standpoint? That kind of thing.
That makes total sense. And Liz, how about you guys?
Well, first off, I love the idea of getting the optional feedback to the leads. So you learn from everybody in the portfolio program. So we might be taking that back to us to use. So thank you. But in general, we get generally positive feedback. We got a lot of positive feedback when we transitioned from Word documents to entirely online systems. The thing that we do hear the most is that the physicians wish there was even more support out there. So more people available to help them in early processing, early writing of applications, and thinking through figuring out how to get data. But we do have resources that we can usually connect those people to. But I think that is probably the thing, the most constructive feedback we get is they wish that there was more that they could do.
Yeah, I'll take that.
Can I follow up on that?
Yes, please.
Yeah, it's great to be in these forums because you do learn something new every time. I'm taking notes as well, but I think our program I remember early on attending an ABMS conference and hearing one of the programs saying, don't try to, run the portfolio program and be the QI coach, because that's just a lot. Well, we sort of didn't listen and do that, and it is a lot. It's a lot, and but it is one of those needs that people mention, and that's why we've also ended up developing this QI training program. But and I think that's probably why you see our FTEs. We're not 4 full FTEs. We have 4 team members who have a small partial FTE, but that is part of what our responsibility is. We do have individual meetings up front with each QI team lead and talk through the project and strategize. And then we offer, we're here at any point, in that process to do that. And we don't get a ton of takers on that, but we do, some people do. And so that is kind of, it's bandwidth, but I think it's important in your organization to know, like Liz said, who are the people, who are the QI coaches, or where is that going to happen? Because that is a need. People come to the QI experience with variable levels of experience, and it's helpful to point to somebody to walk them through it.
Yeah, I think everybody needs that.
Yeah.
I'm going to take a pause for just a second. We have another question that's been posted in the chat. So this is from Ellie. Sometimes critics of non-CME activities note documentation as a barrier. Has this been a piece of feedback you've received, or have your organizations done anything to ease the documentation? Go ahead, Liz.
I'm happy to speak to this. So yes, prior to me taking in sort of over the MOC program here, we had multiple versions of very similar applications for very slightly different things that hadn't been updated in a really long time. It was all on Word documents that had to go back and forth. People would have to physically assign their attestations and scan them, which led to like a lot of back and forth documentation, sort of wasted time to be like, no, we need your signature here. Yes, but you didn't mark all of these boxes. So I think that has kind of done a 180. We have done a lot of streamlining, and we are constantly, about once a year, we go through and say what requirements have changed on any board application. How can we get the most amount of information from the fewest amount of questions, so that we actually have started timing how long it takes people to fill out. Our system lets you know how long it takes somebody to fill out and submit an application. And so I usually will tell people that if you're spending more than 15 minutes on it, you're probably overthinking it, because it should be straightforward. Our attestation process, we do the same. It's all auto routed. We've made things so that you cannot submit unless you fill out the key information. And I think that has resulted in very little feedback since we've sort of gotten it set up and gotten through the initial hiccups about like, this documentation is a lot. So there are ways to sort of balance the information you need versus all of that documentation that you can really bog yourself down with.
Yeah.
Yeah, just to piggyback up on that a little bit. I mean, it's definitely a complex process when it comes to that application, QI project application that we have. We were fortunate enough, again, to have support from other portfolio programs that already existed, and we shamelessly stole from them, and they shamelessly gave it to us, which was such a benefit for us. I would recommend anybody that's thinking about starting up a portfolio program to reach out to us, to whoever would be appropriate within your area, your specialties, to get some help on that application, and maybe electronic attestation, which is a big one too, because it's very complex, and I think you could probably save some time by reaching out to some folks.
And we do have, just to add to that a little bit, we do have several organizations that are CME providers and are also portfolio program sponsors, and they kind of couple their attestation with their CME evaluation, just in terms of your question, Ellie. So we do know that people are doing that as well, and you are very welcome. So Liz, I know we've talked about a lot of things so far today, and one question that I have for you guys is, as a previous portfolio program sponsor myself, I know what value that brought to me and to my program, but I want to know what you guys think. What does it bring to you and your program to be able to say we're a portfolio program sponsor? Liz?
I think I could probably go on for a really long time, but I won't. But there are kind of three big things that I would say. The first is that gives us a support structure to assist our physicians. So it feels like there's one less thing for them to worry about, which is just sort of good practice all around. We also allows us to connect physicians with additional support for if they do need help with other QI, we know who to sort of point them to, but also sometimes navigating the requirements can be difficult. And so it gives them sort of a support person to say, here's the expectations, let's walk through it, this is what you would need. And then finally, I think and maybe most importantly, is it allows us to support quality improvement work and make sure that our culture is around continuous improvement, which ultimately helps our patients. So I think those are the things that this adds.
Thank you. Copious notes. Johnny and Michael, how about you guys?
I mean, I think I mentioned this in the beginning that this has been just a rewarding experience to be a part of, and whether from whether you look inward or outward. I mean, inward, I think we've both been fortunate to meet these amazing people who are working so hard and doing great work all over the organization, and they look to us for advice and support, which is kind of mind-blowing, and so it just there's just a really neat subculture and that's committed to caring for patients and improving work, and that's just incredibly rewarding. That sort of gets you through the day-to-day. And then I think the same, maybe I'm reiterating a little bit, but externally, I think to start a program like this, it has the potential to just be a really positive aspect of your organization. It has all the boxes to check versus maybe other programs in terms of creating value add. Like, they're all there if you go after them. So you can really hit all the quintuple aim components, improving clinician well-being, improving care, working on DEI initiatives, taking care of your staff. So I think, really it's been I feel lucky to have, kind of landed in this space, and it definitely teaches you a lot about compliance, continuing education, what's going on in quality improvement world. You can kind of really hone your expertise in a number of areas.
Yeah, that resonates, I'm sure, with many people who are on the phone. And as kind of an extension of that, Johnny, and before we go to opening it up for questions, what is the single most important thing you would tell someone who is considering the portfolio program within their organization?
Mike, you want to take that one?
Yeah, I think it's a tough question because there are so many benefits from it that we see from the program, as Johnny kind of alluded to, we've alluded to it all along. I think, and to Elizabeth's point, I think ultimately patient care is the most important thing. If you improve quality, you're going to improve patient care. It's just logical. I think another note too, and I just want to give kudos to our ABMS portfolio team here, Tina, Spencer, Sylvia, and the rest of your team. Always so responsive, always help us to engage support from other programs if needed, or from your expertise and knowledge. Again, very responsive, and the feedback that we get from you is so valuable. So thank you so much for what you've done for us.
Thank you for that, sir.
I can't say it better. So I will just enthusiastically second that sentiment. The most important thing I would say is that as you are approaching this, spending more initial investment in your time and energy to develop those efficient processes and get that buy-in is going to be key. And it sounds daunting, but the long-term benefits of that investment really end up help with creating a culture of quality improvement, of safety, as well as sort of the financial stewardship for the institution by helping your physicians with their requirements.
Thank you.
I'll just add on. I
Mhm.
couldn't say much more than that, but in terms of as you're sitting there looking at potentially starting a program, I think the most important thing, another important thing to remember is, it seems like there's maybe fog in front of you, like it's not exactly clear how this is going to go. But just take the next step, get approved as a portfolio program sponsor. And then I think Liz is right on. I think those two components, getting buy-in and working on your processes will just be important up front. And start small, right? Start with one project in your first year and see how that goes. And then you'll be like, oh, we need to improve that, or, that took a while. We definitely need to automate that, and that'll kind of just get you going. So.
Thank you, Johnny. All right, well, let's open it up for some questions or comments for a few minutes. We definitely have some time, and I encourage and invite anyone who has comments or questions to either use the chat or to just go ahead and raise your hand and take yourself off mute. All right, well, I'm seeing no questions come in the chat. Spencer, could you please pull up the slides? We do want to make sure that we touch on and kind of summarize what's been discussed today. So we want to talk about some key takeaways from what the organizations have talked about. So in terms of barriers, organizational buy-in and managing the approval and the QI coaching, like Johnny was talking about, are key. And you have great resources in the three folks that have shared today. The next slide, don't go there yet, Spencer, but the next slide will give you their email addresses. And I strongly encourage you to reach out to them if you have questions about anything. I know that they will be more than willing to help you. So that's kind of what they've been addressing in terms of barriers today: organizational buy-in, and then the approval and the coaching, as well as understanding compliance. In terms of pearls of wisdom, Michael mentioned several things about clinical champions and just kind of having those people in pockets all over the organization, and using the program as a benefit to the clinicians. I think that Johnny has really touched on that today. Tangible things you can take to implement: find a mentor to help you with the program. You've got 3 great ones on the call today. Otherwise, we can hook you up with literally hundreds of others. And it says here, borrow documents, and I'm going to add to that a little bit: beg, borrow, and steal documents. This is not a shy community, and people really want to help. They want to make sure that you don't have to invest the time and the resources and the elbow grease to create the wheel if they've already done so. So they strongly encourage you to reach out. And then, Spencer, could you go ahead and go to that last slide, please? So finally, before I give you their email addresses, I mentioned in the very beginning that this was the first in a series of 3 calls. So the next call number 2, is going to be August 8th. Everybody who is on the call today will receive an invitation to this call. This August 8th call is our regularly scheduled portfolio program call, and it's already got 3 or 4 portfolio program sponsors who are signed up to present on best practices related to attestations and engagement. So you guys will all be invited to kind of sit in and listen to that discussion. And then we'll have another call either late October or early November. The date hasn't been decided upon yet. And importantly, anybody who decides to participate in the portfolio program based on participating in any of these will get a discount off of their application fee. So we hope to hear from you in that regard as well. And then lastly, just to mention the email addresses that you guys see on your screen. The slides will be given to you as well as the recording, so you'll have this contact information for each of the presenters today. And I thank you all again, Liz, Johnny, and Michael, for being with us today and for sharing your experiences with the portfolio program with folks who are interested in, and for being willing to be resources for those people. So thank you guys. And thank you for the claps we see. We thank you guys all for joining us again today, and I hope you have a wonderful rest of the week. Thank you so much. Bye-bye.